I call it pulmonary. That's why I call it pulmonary vascular disease in BPD rather than simply pulmonary hypertension. And I think that'll be sort of one of the major thrusts of what I'll say. Very briefly, I do have some conflicts. I'm a consultant for Bayer and Chiesi Pharmaceuticals. I'll say I might be making some comments about off-label use of such pulmonary hypertensive agents as nitric oxide, sildenafil, bosentan, and the prostacyclins along the way. But I don't think there's anything major that shows my true bias. So anyway, my objectives today then, first to describe the contributions of early pulmonary vascular phenotypes of prematurity. In other words, the susceptibility for the risk of developing both BPD or BPD-associated pulmonary hypertension in many ways is set very early. Often one can identify antenatal factors that contribute to this high risk, and so I'll make reference to some of that work. I'll also discuss the role of impaired lung vascular growth or angiogenesis and how not only does it set the stage for developing late pulmonary hypertension, but also disrupts the distal airspace growth. You know, we call hypoalveolarization or lung simplification as part of the pattern. That also affects respiratory outcomes aside from the cardiovascular issues. And so really the lung circulation that is far more interesting than I ever imagined and plays a role both in the pathophysiology of disease but also the pathogenesis of many ways of some of the respiratory components that we see in infants with severe BPD. And then finally, I won't have too much time to talk about the very important role of developing interdisciplinary team care. Having the continuity of care of our kids with chronic illness, of course, both in the NICU and after discharge, working as teams with our respiratory therapists, physical therapists, speech therapists, cardiologists and pulmonologists and surgeons and others. I think to me, we get smarter by coming together at the bedside and thinking about these kids together. And I think it's so important to have those teams to enhance outcomes. But first, I love to start off with this slide. It's from Alan Jobe, and he got the Howland Award a couple of years ago from the American Pediatric Society. He gave a really nice talk then on RDS as the poster child of neonatology. And he shows this really what looks like a very simple but dramatic plot of how survival has remarkably improved of preemies over the years. And you all know this already. But to see the visual, that's simply what we did with endotracheal tube use and understanding CPAP and PEEP, getting ventilators that are more size appropriate for our newborns and premature babies. The introduction of surfactant, of course, was unbelievable, and the impact of maternal antenatal steroids. And when we look at this survival curve, it's just fantastic. But what really hasn't changed, as you know, is this whole problem of bronchopulmonary dysplasia. And just several years ago was the 50th anniversary since when Bill Northway, who's shown here in the middle, really first described the clinical, radiologic, and pathologic features of chronic lung disease in babies who died at a later stage, describing their histopathology. And so we had a wonderful conference in Stanford to honor him and his work and to think about BPD, the then and the next. And then lo and behold, right behind him is Alan Jobe. And most of you know Alan, and Alan's been tremendous with what he's done with teaching us about how to use surfactant wisely, how to understand its biology, how to mature the lung with steroids. And so we have the then and the next shown here. And I think it just was just a lovely time to get together and think about where do we have to go next to understand this. And we also highlighted at the time the fact that over 50 years, there have been many, many changes of how we think about this chronic lung disease that we've labeled BPD. And we still struggle with that definition, don't we? It's BPD at 36 weeks, characterized by the need of a given level of respiratory support. And yet we know there's so many aspects that we just haven't fully characterized, you know, and they're kind of listed here of how complex this multifactorial origins of this problem have been. First, we know extreme prematurity and injury or developmental arrest is a central component here. We're beginning to understand some of the genetic, perhaps epigenetic factors that may be engaged. Certainly, all of you have done a remarkable job in terms of understanding postnatal factors. hyperoxia, ventilator-induced injury, infection, inflammation. What the heck do we do about the ductus arteriosus and all those postnatal factors, along with some antenatal stresses? And these then lead to early respiratory death before they're officially labeled as BPD. And yet when they die, they have many, many hallmarks histopathologically of lung injury and the adversity of early events that caused early death. And then we have recovery and maybe regeneration to a variable degree. And that's where we have these problems of persistent respiratory disease or late cardiovascular disease as shown here. Not only some of our prams then have prolonged need for support and hospitalization, as you well know, but they can be tough to manage. They stay on ventilators, they have cyanotic spells, they could have recurrent exacerbations and rehospitalizations after discharge. And there's a growing recognition that even premature babies without the tag of BPD made at 36 weeks, even those kids have high risk for what we call pre-COPD or adult chronic lung disease. And along with that, late cardiovascular problems, the late development of pulmonary hypertension, even though may have left the NICU with a normal looking echocardiogram, systemic hypertension, abnormal growth of the right and left ventricles with smaller chambers, and a high enrichment of adults who develop early cardiomyopathy or congestive heart failure. And then also, I then circled this antenatal stress box. And I mentioned Alan Joe, but many folks have been exploring how placental dysfunction and antenatal determinants already set the stage for many of these later sequelae, not just simply within the NICU, but perhaps long after. And we'll talk more about that link between the early antenatal stressors and the later disease, the chronic lung, airway, and vascular disease that we still call BPD often, but now tend to refer to as prematurity-associated lung disease. And Bill, of course, did a beautiful job characterizing the phenotype of our babies. This was in 1967. And we have some examples here of a hyperinflated chest with parenchymal lung disease, a gross pathology of a lung with, you could show the striking heterogeneity of the disease. You see in the upper lobes clusters of lung, which really still remain hyperinflated like grape clusters. And you have other regions in the lower lobes that are hemorrhagic, atelectatic, edematous. And it just shows you the dramatic difference from region to region. In other words, the phenotypes of BPD are in part characterized by variable impact on airways, parenchyma, vasculature, and of course the heart itself. Finally, the histopathology, we're focusing a lot on the disruption of alveolarization as shown in the left lower panel here, and also all these little brown specks or vessels that are dysmorphic or abnormally grown. And this child may not have had overt pulmonary hypertension when they died, but look how abnormally grown the vessels are. And I'll get back to that a little bit later. And what Bill noted was the pathogenesis of cor pulmonale in these kids is puzzling. All of these kids had striking cardiomegaly, including right ventricular hypertrophy. But interestingly, now we're kind of rediscovering, he also said the left heart isn't normal either. The left heart also was strikingly abnormal in these babies who died from BPD of that era. And we've been growing more and more aware of the importance of LV diastolic dysfunction and many functional aspects. But when it comes to pulmonary hypertension, we tended to lump everything together with this tag of persistent pulmonary hypertension of the newborn, or PPHN. And certainly classically, it was the term baby. And here's a baby who's on a ECMO and an oscillator, and we had a tank of nitric that didn't quite work sufficiently. But now we've realized there are distinct phenotypes. And it turns out that it can occur in the preterm infant. There were decades that went by before people really appreciated that even premature babies are at high risk and perhaps even higher risk for sustained pulmonary hypertension in the days to weeks after birth, and can have the same pathophysiology that we see with PPHN in the term baby. And then finally, this whole thing of how does this evolve into severe disease, late pulmonary hypertension? And here's one of our chronic trach patients who has pulmonary hypertension, was discharged home on a ventilator, and actually ended up doing quite well, being decannulated with resolution of disease. But these are at least three distinct examples of how the lung circulation can play roles depending on the clinical context in which we assess them. And to further look at this, we made this schematic here. High pressure in the fetus remarkably drops immediately at birth, thanks to oxygenation, ventilation, getting rid of fetal lung liquid, all the release of vasodilators and things like that, normal transition. We also know that in PPHN physiology, there's the sustained elevation of pulmonary artery pressure, predominantly driven by high pulmonary vascular resistance. Or we could have sort of a roller coaster ride of delayed transition, where you have this sluggish decline in pressure until babies make this normal transition during the first 2 or 4 weeks, or even a little bit longer at altitude. But they eventually have a normal lung. It just didn't transition sufficiently and rapidly. Yet it truly isn't the same as the PPHN physiology that really leads to pretty profound hypoxemic respiratory failure. The other phenotype, of course, is more the late. That is, some of these infants who make the transition, especially our premature babies who then develop chronic lung disease, they have this progressive rise in echocardiographic features of late PH that may not have been apparent really. They may have made the transition apparently pretty well. And yet this can raise its ugly head along the course and complicate outcomes. And there are different ways of categorizing them. Here we have the early transient forms of PPHN, and this is how traditionally we would cluster some of these problems. But we've learned that also with this late sustained pattern, we'll be talking about prematurity and BPD, but other developmental lung diseases, CDH, Down syndrome, congenital genetic abnormalities of lung hypoplasia, ACD, TBX4, many of these things, not truly PPHN, yet they could present with many PPHN type features. And so how do we characterize them and study them? But certainly the baby with prolonged echo abnormalities requiring late support, especially with pH targeted treatments, all of those babies now were readily doing the genetic evaluations to rule out developmental lung disease, including some of our premature babies. We're starting to look at them beyond just term infants with refractory PPHN. So how does this fit in overall with pediatric pulmonary hypertension? Well, this slide is from some registry data from our PPHNet when we launched as a group. And it shows supposed group 1 PAH, and that's about half of this pie. And this is what we traditionally think about with pulmonary hypertension in kids, pH associated with congenital heart disease in particular, or idiopathic or heritable or genetic types. And they would sneak in this quote unquote PPHN, the adults did just to appease us pediatricians, right? As a small sliver of transient and not a very big signal. But when we looked at our registry from a number of sites, we found that this was actually populated by a significant number of preterm infants, 8 per 100 live births, and more profoundly present in those who are more extremely preterm. And then when looked at this pie, of course, it's this blue part of the pie is about half the population. And that's where we had our group 3 or lung associated disorders. And about half of them were related to hypoxia or chronic lung disease. Half of the half, or 46%, were BPD in particular. The other big signal was CDH, of course, but you can see the list of more rare kinds of development abnormalities that really we worry about, of course, in the NICU itself and beyond. But I show this because this is actually underreporting how significant pH in the early transitional period in the NICU in the first weeks of life, because these are kids we consented to be part of a registry. And the signal is even bigger than we show here, yet it sort of woke us up to say, how significant is it that we have this problem? And we better pay more attention to understanding it. And certainly early on, high mortality was noted. The group in Boston, this is quite a while ago now, but they showed early mortality based on the severity, more profoundly there with more severe PAH than those with mild. These were kids who actually went into the cardiac cath lab for the diagnosis. You see this incredible drop in survival and then a flattening. And I'll get back to this pattern a little bit later. If one also looks at a few of the early prospective cohort studies, you can see that about 29 to 58% of the severe BPDers by old NIH criteria had significant echo abnormalities at 36 weeks. Less so if you're none or mild, but still present in some of them. And a very striking part of this puzzle then was how to associate disease severity with pH. In other words, this remarkably big signal makes me wonder, why is it that they all don't have this? And or is it causing the severity, of course, or is it simply a biomarker of how sick these kids are? And those are challenges we'll talk about in a bit. The other piece that is so interesting is that we tend to think about neonatal pH, at least in the old days, as being more a question of vascular tone and vascular reactivity rather than some of the structural features we've come to identify. And so these are four pictures I just want to show quickly, showing you vascular remodeling. You see the smooth muscle around some of these small pulmonary arteries, very striking in a kiddo with obvious interstitial disease, alveolar simplification, other markers of profound BPD. But this vasculopathy also includes vessels that were actually occluded because of the remodeling, especially in the distal lung. I already showed you this idea of dysmorphic or reduced vascular growth leading to reduced surface area, which may predispose for pulmonary hypertension, but may also contribute later on to some of the exercise intolerance that we see, both in young children as well as some of the young adults that have become more problematic as we follow them. And then finally, some abnormal findings that aren't so uncommon after all. And that as you see this really blood engorged abnormal vessel around this small airway and this funny location, if you looked at this intrapulmonary bronchopulmonary anastomosis, you'd say, well, this is ACD. This is classic alveolar capillary dysplasia. This was not. This was BPD, but this baby had minimal detection of the gene that's responsible for ACD, FOXF1. And it turns out that many of the signals we're learning in rare developmental lung diseases are actually disrupted in preterms with lung injury from a variety of causes. And so there's some overlapping features of structural dysfunction, development of pH that's in common. And I always say that the rare inform the common, meaning these rare genetic disorders and pathways are helping us understand why is it some kids have severe pH who were prematurely born. So I put it together this way, kind of like the figure I showed you before, but really focusing on pulmonary vascular injury, the idea of altered fetal programming being so important. I'll get back to this, but a few different aspects of this beyond just pulmonary hypertension. And that is you have abnormalities of endothelial cell-derived vasoactive products. Nitric oxide is released at birth. It contributes massively to the dilation at birth normally. And it's impaired after antenatal injury and other perinatal factors. Increased tone and reactivity and structure can all contribute to this development of pH. But also we see, as I showed you, impaired angiogenesis, reduced vascular bed, which then even with normal cardiac output through this hypoplastic lung circulation may represent a significant hemodynamic stress, setting the stage for more aggressive late onset pH to follow. And then finally, what's always fascinated me, and I'll talk more about this, is the importance of the endothelial cell, the vascular itself, to signal to the epithelium. We call it angiocrine signaling because it's vascular signaling, paracrine signaling, that tells the epithelium to develop the alveoli, develop the surface area. And these vascular and epithelial growth go hand in glove together. Yet it's not simply the vessels passively following what the airway does. It's this interactive signaling crosstalk that leads to the risk for both pH and for BPD, which I'd like to briefly talk about. Well, we've started off in terms of a little bit of laboratory stuff, developing an animal model in sheep to study PPHN near term in these animals. And we did that by partially occluding the ductus arteriosus surgically. We did surgery, then let the animals sit with a little bit of occlusion of the ductus, enough to cause a hypertensive stress, but these animals were not hypoxic. So after about a week or so, we delivered them by C-section. They had classic PPHN physiology with hypoxemic respiratory failure, with extrapulmonary right to left shunt. And so we studied that, did a lot of stuff we're very excited about. We kind of ignored what you see that's so obvious here. That is, when you take the lungs out of the PPHN lambs, they're tiny compared to the normal term control animal. And when you actually measure lung weight to body weight, it's down. And of course, the vessels are fewer, as we showed that this hypertensive stress in utero, the vessels don't grow very well, which I think is part of how antenatal determinants cause disease in prems, and we'll talk about that more. But the thing that was so striking is this, that if you look at the distal lung pathology, you see these more dilated distal lung air spaces, this decrease in alveolar development in these sheep. So why is it that the alveoli, the air space, would not develop when you're simply giving this intravascular, a blood vessel stress? And so that crosstalk was interesting. So we did a number of studies with rats and other kinds of species that if you simply give an inhibitor of angiogenesis to these animals at the time of birth and then leave them alone through infancy, they not only have smaller lungs that you see here from fumagillin and thalidomide, you don't only see pruning of the vasculature, but look at how simplified the lung architecture is. So in other words, disruption of angiogenesis impairs alveolarization along with causing the pulmonary hypertension. If you use a specific inhibitor, in this case a proangiogenic stimulus called VEGF, a receptor inhibitor, a single shot after birth, and then leaving the animals alone, no hyperoxia, ventilation, no other changes. Look how simplified the lung circulation is and how the vessels themselves don't grow very well after using this inhibitor, even at a couple of weeks of life and then into adulthood. And this, of course, fascinated us because instead of seeing these nice brown spots in the adult lung, which show vessels that are filled with barium, you don't really see those vessels there. And instead of the nice, septation and complexity of the adult lung, again, you have this emphysema type pattern. So we came up with this kind of a schematic. We've spent a lot of time studying specific mechanisms by which the endothelial cell, as you see here by the EM, actually has pretty close contact in the developing alveolar type 2 cell, our source of surfactant and source of other AT1 cells and things that are really essential. And this crosstalk then leads to some of the septation that's required for successful distal lung growth or alveolarization. And this is simply a cartoon that shows this endothelial epithelial crosstalk. That early disruption of vasculogenesis or angiogenesis leads to this impaired signaling with impaired alveolar development. And that's part of the thinking that we had. We further then went on to say, gosh, if this is true, what do we know about human disease? Can we show that, like our animal models, that some sort of maternal stress, whether it's chorioamnionitis, preeclampsia, many ways we could mess up the placenta, right? That somehow that messed up placenta speaks to the fetus, alters fetal programming, leading to reduced vascular and alveolar growth, setting the stage for a more difficult NICU course with impaired gas exchange, maybe PPHN physiology, or even the progression to late PH, and then the late cardiopulmonary sequelae. And again, we were mostly focusing on disruption of angiogenic signaling. And there are a number of biomarker studies that have confirmed that you have fewer circulating endothelial progenitor cells, fewer circulating proangiogenic factors such as VEGF, and more anti-angiogenic factors present. So it seemed to come together that this should be the case. And certainly more lung studies we did with an IUG model in sheep. I won't go into this too much, but simply causing the placenta to be dysfunctional, not to grow well, from a heat stress to pregnant sheep was enough to cause neonatal lung hypoplasia. And this is the IUGR lung. And of course, we're all interested because IUGR has been such a striking signal for worse perinatal outcomes, more long-term lung function, mechanic dysfunction during infancy and childhood. And it's also associated with striking pulmonary vascular disease in vitro. These endothelial cells don't grow very well and they don't form tubes very well. We further looked at these models uh, by giving the mimicking preeclampsia and then mimicking chorioamnionitis in rats. And we did this by doing intraamniotic injections. S-FLT is an endogenous inhibitor that's markedly elevated in preeclampsia, striking biomarker. But S-FLT itself inhibits VEGF, and sure enough, it causes the same kind of placental and neonatal abnormalities that we've previously reported. Giving inflammation endotoxin to mimic chorio, the placenta is strikingly abnormal, and they both become pro-inflammatory as well as anti-angiogenic. And so these are what the newborn lungs look like. Endotoxin and S-FLT to mimic chorioamnionitis or preeclampsia. The vessels don't grow very well, but look at the distal airspace. And so these models then made us think about that endotoxin is sufficient to cause these changes. And more recently, one of our fellows, Paula Diaz-Maya, an NICU fellow, showed that there's a progressive or a loss of the ability of the lung vessels to grow over time. And then if you follow these animals in experimental choreo by looking at vascular remodeling, the walls of the vessels get thicker, more smooth muscle cells, and RVH progressively increases, as does the echocardiographic metrics of progressive pH. And this was fascinating to me because it shows that choreo not only has its immediate short-term effects in the early postnatal period, but even if you disrupt growth at that window, over time you could see progression of cardiopulmonary abnormalities, very reminiscent of how we see late pH can appear long after the transition's been made in the NICU and certainly after long-term follow-up. So we were interested, does early pulmonary vascular disease then, as suggested by all this preclinical work, predict the risk for BPD or BPTPH in preterm infants? So we did a prospective studies and did a lot of things, but the major thing to highlight is we did simple echocardiograms at day 7, and then at 36 weeks at the time we make the diagnosis of BPD and its severity, and did a bunch of other things as well. But was really striking to us that was so similar to the laboratory findings as shown here, that is early sign of pulmonary vascular disease, and sometimes they're kind of subtle, simply septal flattening on day 7 when we did this echo, was as strong a signal that was a determinant of BPD severity as was decreasing gestational age or decreasing birth weights or other kinds of factors. Similarly, if you had these very abnormal, or not even extremely abnormal, but these striking findings of septal flattening or RV dilation at day 7, it was strongly associated with the later echo at 36 weeks of showing evidence of late pulmonary hypertension. And then finally, sort of along the lines of what I mentioned before about the airways or airspace disease, we found that an abnormal echocardiogram at day 7, simply some element of some RV stress or pulmonary vascular disease that may be present, not really necessarily PPHN at all. But if you then look during the first 2 years of life, they had more ER visits for respiratory issues, hospital admissions, asthma exacerbations, and other kinds of things. So a strong biomarker, but also I think is really pathogenically linked with, again, the respiratory abnormality, not simply the pulmonary hypertension itself. And certainly when we looked at our cohort, we found that pulmonary vascular disease at day 7 was strikingly associated with risk for poor outcomes to follow. And so we did some angiogenic stuff I won't get into. So that really speaks to some of the issues of what begets pulmonary hypertension. But the other observations at a number of different sites, including Rob Sinkin's group, and I think this was in Boston, showed that if you find early pulmonary hypertension itself, now beyond just this pulmonary vascular disease question, you found that it was associated with higher mortality in preterm infants with BPD. And these are echoes that were abnormal early on again, and they were associated with worse pulmonary outcomes, higher rates of the need for ventilation, and higher mortality and other kinds of complications. Another cohort studied through the first year of life from the Children's Hospital Neonatal Consortium did echoes somewhere around 34 weeks and found that 22% of the preterms born less than 32 weeks had echo abnormalities. And again, clinical features, higher mortality, more vent support, longer duration of ventilation, worse respiratory severity. And also, as suggested from what we did with a simpler cohort, they found that in these babies, they also required more readmissions to the hospital, sometimes be placed back on a ventilator after readmission. And so again, this idea that early echo findings were associated with pH and poor outcomes in premature babies. Well, what about nitric oxide then as a vasodilator? One would think it should be the cat's meow, should solve everything, right? And certainly one of our first kids we ever treated with NO who is prematurely born, we were so hesitant because so worried about toxicities and many issues. Yet we had this profoundly hypoxemic baby who, despite many different ventilator strategies, remained hypoxic. We tried oscillation, which is why these mean airway pressures are so high early on here, as shown. And what we found in this baby was that the echo showed a significant extrapulmonary right to left shunt. We began nitric oxide at relatively low doses. We were able to drop the mean airway pressure, improve oxygenation. We had a second brief course of inhaled NO. And this kiddo came off the ventilator and had a wonderful follow-up in the ambulatory clinics through high school, really did quite well in a child who otherwise we didn't think was going to make it. And so we got very excited that indeed nitric oxide might even work in the prem with PPHN. And a number of other sites showed something similar. That is, this is from a Finnish group, Mikko Holman's group, that he gave nitric oxide to prems with respiratory failure, PPHN, could see improved oxygenation during the 18 hours they were treated here, drop in oxygenation index, an increase in arterial to alveolar ratios. And again, there are many, many little case studies here and there that showed that. However, when we did, and many people did, large multi-center trials giving nitric oxide, it did not change the incidence of BPD at all. And so where's the discrepancy and what's going on? And so Roger Saul, who does a wonderful job leading the Vermont-Oxford network, he wrote this statement. And he's a dear friend, even though he was very unhappy with inhaled NO. He said, in preterms, it continues despite little evidence, that is, we're using it all the time, and despite statements from the NIH, the American Academy of Pediatrics, and others. And centers spend nearly $300 million in 1 year on unproven therapy. And so it's related to the misuse of NO. But we have to remember is this, that those large multi-center trials of over 800 babies, at least 3 of them, 4 of them, none of them show this effect, and yet none of them included the concept of pulmonary hypertension. None of them phenotyped the babies as being at risk for PPHN or having PPHN. And I think this is something, a newer concept than what was started way back when we thought we were so smart that giving nitric is going to solve everything. We thought of nitric more as an anti-inflammatory, an antioxidant. Weren't thinking too much about what it meant for pulmonary hypertension. And so over time then, a lot of controversy. And when we got together to develop guidelines, we were trying to be very careful. This is from American Heart, American Thoracic Society. But we end up making a group decision that we would support nitric oxide because we said it can be beneficial for preterm infants with severe hypoxemic respiratory failure that's predominantly due to demonstrable PPHN physiology rather than parenchymal lung disease, particularly with prolonged rupture of membranes and oligo. And so that was the statement at the time. And what's happened since then has been really intriguing, hasn't it? A lot of papers have come out in retrospective assessments of babies who got nitric, and yet their outcomes were worse. Mortality was higher. CP and neurocognitive issues were more prominent. But those were uncontrolled studies and observational registry data in which they simply gave nitric to those who were doing more poorly than others. So many of the very risk factors for mortality and morbidities were already present in those patients. And so it's really hard to discern what's causing disease, what's perhaps preventing some. Then a couple of interesting observations. One was from several years ago, where Kevin Ellsworth and a group through the pediatrics practice looked at association of early inhaled nitric oxide, specifically in babies who were felt to have some element of lung hypoplasia. Now, it's really confusing because how do we really know lung hypoplasia? It's sort of a clinical call right now based on radiographic, clinical course, and other things. We can't really measure the lung itself. But if babies who were entered into the electronic health medical database had lung hypoplasia and were diagnosed with having PPHN, the mortality was pretty striking. But those who were diagnosed with PH who received nitric oxide had a nice signal of almost a 30% improvement in survival. And so what was mostly emphasized was the lack of reactivity and the high mortality, except in those who really carried this diagnosis of PPHN, which is really intriguing, of course, because again, not all prematures with hypoxemic failure have PPHN. And so we have a targeted therapy for those babies that may be particularly responsive. More recently, a Canadian study performed an assessment of nitric oxide multi-center study. And I'll just show you briefly their findings, that at least early on in the first few days of life, if you trialed babies with nitric, those who responded to it had a much more benign outcome, a much better survival rate than those who were non-responders. Given later, it's less of a striking signal, but at least here they incorporated making the diagnosis of pulmonary hypertension as part of this. And yet, there may be a number of reasons why they responded or didn't respond, but it looked like there may be a protective signal there. So we're really still trying to sort out to whom we should be treating and why. And we have to be very careful with it. Its use is markedly increased, as shown here. We need to be specific with phenotypes and what we're using nitric for. Are we using it for rescue therapy for acute PPHN? Or are we giving it just to improve oxygenation, perhaps, in those who don't have PPHN? Or is it related to postnatal use in those who have evolving or established BPD? So much to still learn about how effective this is. But I think one take-home lesson that I think is really vital, we learned as much about PPHN physiology and respiratory failure from those babies who failed to respond to nitric than those who did. In other words, when we didn't see responsiveness, we'd have to backtrack and say why. And most commonly, frankly, it was related to this heart-lung vascular interaction, that pulmonary hypertension isn't just one thing. There are many features. And that although we think about constriction and relieving constriction with nitric oxide, it's how we really ventilate the lung to recruit the lung to distribute NO gas to be of sufficient efficacy. And certainly it's the management of the lung disease itself, the nature of the lung disease itself, that has much to do with this. And clinically, of course, many of you have probably already seen this. Take the same baby who's an NO non-responder. It's not working, you shut it off. Then you put them on with a different ventilator strategy, different recruitment strategy. Maybe it's oscillation. Maybe it's a meconium baby. We're just simply slowing the rate and doing other things with standard ventilator practices. You suddenly then restart the NO if you still have echo abnormalities. Suddenly they're a responder. So the vessels haven't changed that dramatically. And yet what you do with the lung matters tremendously. Likewise with the heart, cardiac dysfunction, the presence of shunts, LV diastolic dysfunction, pulmonary vein stenosis later in the course. So it's really the intricate dance between heart, lung, and vessels, which really dictates how we should be managing these kids. Nitric oxide is part of the process of discerning reactivity, part of the therapeutic strategy, but without the targeted neonatal echo story that's evolving has been fantastic. Understanding what's going on with how to optimize the lungs safely with minimizing and ventilator-induced lung injury. It's really these interactions and overall physiologic integration of physiologic principles into care that seems to make the difference. And that's what I think about when we think specifically about BPD-associated pH. I have the same boxes here that we like to use. We have the lung and the airways, tracheomalacia, other issues. We have the lung disease in terms of the complexity of what's going on in the parenchyma and the airways and things. Pulmonary vascular disease, of course, and what's there in terms of structural features. But, pulmonary vein stenosis has been some raising its head these days. And of course, the cardiac performance issues and the shunts. And it's this integrated strategy, I think, is how we best improve outcomes of BPD-associated pH, not because we have a magic bullet, but certainly having choices now of different vasodilator therapies has really made a nice difference. Now, I just want to briefly show you this. This is what we all learned in our physiology courses in medical school and stuff. Pulmonary vascular resistance clearly related to lung volume. Low lung volumes with atelectasis, you have an elevation of PVR. Hyperinflation, you have an elevation. But hitting that sweet spot of what we call functional residual capacity, or FRC, that's where we want to live. And so how do we know that and prove that is very, very difficult, as you know. We're getting smarter with electrical impedance tomography, with lung ultrasound, many imaging techniques. But right now, when you deal with severe BPD, this is the kind of lung we're thinking about. This is really severe disease. You see these areas of hyperinflation, almost cyst-like lesions, along with atelectatic, edematous, or fibrotic regions, and different airway calibers to these different lobes. And so it's this dramatic heterogeneity of lung regions, different time constants, that makes it so hard to know. How would we know we're at FRC, especially in this kind of lung? And we're still trying to meet this challenge. How can we most effectively distribute gas throughout all areas of the lung in the setting of heterogeneous lung disease and severe BPD? And this is still a major challenge. We are seeing a lot of kids who are surviving now, who are spending more time with evolving or established severe BPD, a number of whom remain on invasive ventilation, even beyond 32 weeks and so forth. So we have to figure out then if we're going to treat their pH, how to best use the ventilator, use respiratory support, how successful can we use with non-invasive respiratory support, how can we apply treatments such as nitric oxide or other pH targeted agents and tackle that. And then finally, I want to get back to this physiologic basis for the pulmonary hypertension. As we mentioned, in the premature babies, as it is in every form of pulmonary hypertension, post-op cardiacs, kids who have other diseases, the pressure itself, as we measure it, reflects pulmonary vascular resistance, which is predominantly the vascular disease. It reflects flows and shunts, whether it could be a ductus and ASD, which is rising to the forefront as being problematic in many kids, or it could be the left heart itself. There's the wedge pressure, pulmonary venous hypertension is contributing from LV diastolic dysfunction or grossly abnormal structure of the LV or systolic dysfunction. So we have to sort out that not all babies who have an abnormal echo are we happy that we understand their physiology completely, because it could still be how much is vascular, how much is flow related, how much is left heart or wedge pressure, pulmonary venous hypertension. And this is the essence to me of the bedside physiology, integrating the physiology with your care, choosing the interventions to match the changing, evolving physiologies. That's where being at the bedside, the role of serial echocardiograms along with serial changes in how we ventilate flow volume loops and other things we could use. Many of those tools, I think, will make a difference rather than there being a single magic bullet per se for pH therapy. So the echo's been fantastic and many things we could assess, many things to learn about it still, but this has been so exciting to watch this field evolve over the last decade and to see it applied successfully with the complexity of these interactions. And I think that's what really is going to improve or already is improving some of the outcomes and reducing some of the comorbidities. We do still have bullets to use that are currently endothelial cell based. I mentioned the nitric oxide cyclic GMP with NO, but endothelial cells can make endothelin. And that's a potent constrictor. And we have at least 3 different agents now that we can use, boson 10 being the most prominent. Nitric oxide, again, we could use inhaled gas or sildenafil, which works by sustaining the cyclic GMP that's produced by nitric oxide by blocking its degradation. But what's really exciting to me is this riosaguat here. It's a soluble guanylate cyclase activator. You can see here the soluble guanylate cyclase would be sitting in the smooth muscle generating GMP. What's exciting about these drugs is they target the very same enzyme nitric oxide does. But if this target is sick, oxidized or not present, NO can't work. And yet, if it's there and oxidized, some of these drugs can still work to generate cyclic GMP. So if you have your NO non-responsive baby, term or otherwise, sildenafil hasn't done much, which we often see we could transition readily, but if it doesn't, what's exciting now and still has to be proven and studied in more detail is you have another way of stimulating GMP to perhaps perform the vasodilation you're trying to target. And so that's really where some of the things are changing. The prostacyclins we continue to learn more and more about, and boy, we have oral, systemic, inhaled, many different choices there. But you have to remember these are primary vasodilators. And so with structural disease, impaired vascular growth, and many issues, dilation isn't going to be enough. And there's an exciting story now of evolving understanding of sotatercept, for example, drugs that could target structural changes independent of whether they're dilated or not. So in pulmonary hypertension as a field most broadly, tremendously exciting data in adults with severe disease, starting to translate it down to older children with severe disease. Someday, maybe in a subgroup of kids in the NICU, we'll be pulling this off the shelf, but a lot to be learned before then. Finally, late outcomes. I told you about this death signal that Mary Mullen described in Boston many years ago, still seen in Sonny Aron's work from Groningen. She showed nicely that yes, in their population of neonates, prems with BPD associated PH, significant mortality. But then it flattens out after about 6 or 7 months. And you see kids with modern follow-up and care and multiple interventions, the pH can actually resolve and actually resolve in the sense that many of these kids come off their pH specific therapies. In the past, it was almost unheard of in any other form of childhood pH. So very exciting to see this. And yet we also know we're not completely off the schneid, that adults can still remain at risk. Here's the emphysema of a 30-something adult born preterm. And you can see the marked hyperinflation and the cardiac cath had severe pH and also pruning of the vessels, kind of like those rat lungs I showed you way back. The conduit arteries are tiny, the branches off them are few. And this young adult needed an early lung transplant because of the sequelae from the NICU. So an extreme example, but we really have to learn more about the developmental factors, the intrauterine programming and antenatal stresses that may cause problems in the transition. But they may also set the stage that you don't grow as well, and that secondary injury or just over time, you're at risk for adult onset of pulmonary hypertension more broadly. And there's some data supporting this concept, even beyond prematurity itself. So many interesting features. So to summarize then, we think of pulmonary vascular disease, at least in three different periods. Early, meaning early PPHN. We have to rule out high flow and other causes, not just the PPHN from vascular disease. Could be delayed vascular transition, the roller coaster we talked about, or maybe it's just an interesting biomarker, and we could change our interventions to really then, knowing that they are risks for BPD, do something different with their care. But it still boils down to heart, lung, and vascular targets in terms of how we manage these kids. It then can evolve into chronic disease, recurrent cyanotic episodes, established or severe BPD. You're already starting to see structural features of pulmonary arterial remodeling. And then finally, the late case I made reference to, where you can see early exercise intolerance in adolescents and young adults, the rise of echo abnormalities, and maybe even adult onset where the disease progresses. So still much to learn over time. So in conclusion then, pulmonary vascular disease of prematurity contributes to the pathogenesis of BPD, not just BPD-associated PH. Identifying the drivers of these early problems, perhaps from antenatal factors that we could incorporate into our assessments, leads to this idea that we could maybe prevent BPD. That's the vascular hypothesis. We have to treat the underlying lung and cardiovascular disease beyond the use of pH drugs alone. And again, I didn't talk much about care across the lifespan, but hinted a lot at it, but I think it's really vitally important. And then finally, this is a small group. We now have 55 centers as part of our BPD collaborative, and they've been a wonderful group to work with. And thanks for your attention.
Thank you, Steve. That was a wonderful overview. As again, look, you started with this evaluation and the history of BPD, increased survival, complexity of the disease, which led to that. Well, we need to learn more. We need to build this understanding, and then you explained to us the concepts behind PPHN, because that's the term it was given with the variable pathology. But if you look further, the predominance was still BPD, which I thought was really interesting. And then you went to what I'm guessing is decades of research looking at pulmonary vascular injury and how these patterns were like. And what I really picked up from that is that it's not just growth, but limited growth, abnormal growth, which if you then have normal blood flow will lead to increased resistance during that blood flow. I thought that was a
Yeah.
really message to me, which I picked up there. And then you did some about therapies, particularly focusing on preterms with BPD and nitric oxide, when to use it, when maybe not to use it, and how that is sort of appropriate. And then the PPHN phenotypes, which indeed also amongst many groups has come forward. There's different measurements what we can do, and then we try to address those. Not every therapy works, and then the long-term follow-up. Yeah, this is not a disease maybe just for us, maybe it just continues on for a lifelong session. I thoroughly enjoyed this summary. Very much thank you. I'm going to go to some of the questions which are there. Of course, some clinical questions. The main one, and that's what of everybody's question, how can we get to FRC when we're ventilating BPD babies?
Yeah, that is the mystery. You hit it on the head. That is such a tough question because what is optimal in terms of gas exchange? What is optimal in terms of with chronic invasive ventilation, especially, but even with non-invasive support, as you know, adjusting NAVA, adjusting levels of nasal CPAP or high flow. How can we make our babies far more comfortable, less dyspneic over the long haul as part of the therapy? And so there's no magic number for FRC. And yet what I'm excited about that's really breaking now is that you could use electrical impedance tomography, for example, to look at the distribution of the ventilation, but also distribution of the flow. And you could actually get VQ measurements from it. And there's a beautiful paper from Boston that came out recently. Jessica Shui is the first author, and what she showed was just adjusting PEEP in these severe babies as they get older on a ventilator and are so complex. Using EIT helped her get a sense of distribution of gas with these changes of the knobs on the ventilator. And so how we do chronic phase ventilation, I think is going to get better and better, and yet it still remains a physiologic challenge now. So it's not simply an X-ray. It's not just counting ribs, because that is not sufficient. And with striking heterogeneity from lobe to lobe, you have a hyperinflated lobe, an atelectatic lobe. How can we readjust things to let the hyperinflated region decompress while you recruit the other? And those are things that will impact pulmonary vascular resistance. But how do we develop that wisdom and experience? Still takes a lot of work. But it's more than just thinking I'm going to change the knobs. FRC means you're going to have a 9.5 or 10 rib expansion, regardless of how we get there. As we change the peeps to get there, boy, we better be dropping that rate, because you can't, too much rate and high peep, you're going to start having more gas trapping. So these are all things we talk a lot about in our consults or together as our case conferences and researchy stuff we'd like to do as a BPD collaborative, because FRC as a concept is great, but if you have heterogeneous disease, we have to think about region by region and doing what we could do without causing more harm. So it's a long-winded response saying, I don't know, but these are the kind of strategies that are integrated with care in babies who have PH. Yeah.
Yeah, thank you. Yeah, I can't wait for the EIT to become sort of something like a little band. That's it. And you put it on a
That's it.
machine next to the
That's
ventilator,
right.
see the
That's
two
right.
lungs. Pramod had a question which is about post-capillary pulmonary hypertension or pulmonary venous hypertension, which in BPD seems to be associated with systemic hypertension. And he and his group in Monash have been studying it for a while. What's the primary pathology in that? Is there
Oh,
something with pulmonary
yes.
vascular disease or?
So interesting, isn't it? Because I think, you could already see differences. And Arvind Segal did some nice imaging of some of the systemic vessels, and they're not structurally normal from his imaging. These aren't the really tiny vessels systemically, but, branches of the aorta itself, and he could see changes that way. We know metabolically there are likely changes. Way back when, gosh, we noted when we did follow-up of our premature babies, really a high rate of systemic hypertension and BPD compared to prems without BPD. And we were so interested because what is this heart systemic circulations? How do they crosstalk? And so in that era, and I think it's still true, we realized the lung was actually a metabolic organ, that the lung normally clears about 40% of your circulating norepinephrine, your noradrenaline, right? So we measured this in the cath lab. But as we made these measurements, number one, all of the norepis and epinephrine levels were high in BPD. But number two, rather than having this 40% drop in norepinephrine that we saw in other patients who underwent cardiac cath, there was no reduction in norepinephrine across the lung. In fact, in many of them, there was a net production. So it made us think that the sympathetic nervous system is hyperactive. And sure enough, there's been some markers of the importance of these circulating mediators that may be contributing to these changes. But in addition to simply having circulating neurohormonal mediators, the vessels themselves are probably changed as well because of the exposures and other kinds of things. So as we think about maturation of the lung circulation, there are probably maturational effects of the systemic vessels that could be adversely affected directly from some of the injurious things that happen, or indirectly through different mechanisms that affect the lung also. But it may be that these kids are under tremendous neurohormonal stimulation that changes renins and aldose, and that sets the stage for programming these vessels to be abnormal even into adulthood. So I don't know if we lost you here or I'm lost. Did I freeze here? Oh well.
I think Kurt's computer has crashed or frozen. Um,
Okay.
the next question that I see in the chat, I think one of them has already been answered. But someone has asked what your thoughts were on inhaled corticosteroids to help in pulmonary remodeling and reduce pulmonary hypertension.
Oh gosh, I think anything that could really enhance, the protect the lung from inflammation. I don't think it's absolutely one compartment or the other. And I say this is experimentally. We did studies with, for example, antenatal corticosteroids when we did our chorioamnionitis model in the rats. So in the model of the rats, you may remember that they get pulmonary hypertension in infancy. Their lungs don't grow very well. And so what we did was said, well, what do steroids do? Because we knew that too high a dose in animals of steroids postnatally in themselves can inhibit alveolarization. But what we found was this: if you treated the pregnant rats who had chorio with antenatal steroids, we could actually prevent the pulmonary hypertension and some of the other changes in the infant rats. And Elizabeth Taglauer from Boston took some of the placentas from these animals and is also doing some human studies too of placentas from chorio. And she found that the steroids themselves may have protective effects. So it's almost like save the placenta, save the baby. And maybe the steroids themselves can restore some of the placental pathology that's protective. Or it could be that the antenatal steroids that the fetus sees is where the protection is. So all those mechanisms are possibilities. But I think that I think it's been kind of a very interesting question that if we could do things, if not directly related to the vessels per se, the better we could lower the oxidative stress, the inflammation in general, right? We think the lung and the lung vessels can do better. Yeah.
Thanks. And there's one last question in the chat, and I can see that it's past two. Um, Maybe we can get to this one quickly. We described a variety of phenotypes for pulmonary hypertension. Um, Considering that there are a variety of phenotypes, should we move away from PPHN as a label altogether, or is that label still useful?
No, well, that's the question. It's so important. We should be teaching the different phenotypes of pulmonary hypertension. We should reserve, I think, PPHN to the specific physiology to which it was originally described, and that is the presence of right to left extrapulmonary shunting is really essential. If that's a contributor to the hypoxemic respiratory failure, to me, that's PPHN. If you say that we just have high pressures, but we don't have extrapulmonary shunt, it's still important to know the physiology. But I think if we lump it all together and don't break it out by the different phenotypes, we're going to end up doing more harm than good sometimes. And the group in Groningen did this beautifully, Rolf Berger and Sonny Arens, and they showed that we showed that early abnormalities at day 7 were associated with all these things. But they said, now wait a minute though, even within that day 7 group, you have at least 3 different groups. And that's the PPHN, the right to left shunt. You have the left to right from high flow shunts, a big ductus that may be contributing. And the third was something where they didn't see either shunt right to left to right predominant, but had pulmonary hypertension. And they left out, of course, the idea of how can we better assess the left ventricle for the pulmonary venous contribution. But I think that's where the studies, if we're trying to study whether early nitric oxide or early pulmonary hypertensive therapies are going to be effective to prevent the sequelae that we all worry about, we have to subgroup them. And the response to that is by using these physiologic assessments serially. It's a dynamic window where changes can occur rapidly. Look at the ductus, look at systemic hemodynamics, look at pulmonary hemodynamics all together. And unless you have truly right to left extrapulmonary shunt, I would really hesitate, especially an extremely preterm baby, starting nitric oxide. If I start, I'd use really low doses, but I'd also make sure I target what we're doing with systemic, cardiovascular performance. And when Patrick McNamara in Iowa did this, it was really interesting because they more selectively defined the physiology and then gave nitric or didn't. Simply by using that, they saw about a 40% reduction in severe IVH, grade 3-4 IVH. And now as post hoc, it was a historic controls were used since when they launched their targeted neo-echo program. But the philosophy is the same. That is, we have to look at the overall baby, the integrative physiology. We have to look at the changes in these, at least these three compartments, if not the lung disease itself, of course. And to me, if we don't define those phenotypes, then it gets to be a mess. So that's why being more precise of what PPHN means, simply referring to its pH that's flow related, pH related to cardiac dysfunction or combinations of those. To me, those are very important differences to distinguish these. Yeah.
All right. Thanks, Asil. Can you hear me? Yeah.
Yes.
Okay. Look, sorry again, some IT crashes. Definitely need to get another laptop. Look, it's 8 past. I hope Asil took you to the questions at the end. I think we're gonna close off. Steve, so much thanks for presenting for us late in November night. For everybody here, we're back next week with Adenopacatheria. It's going to talk about surfactant administration and non-invasive type, and we'll continue on this on a weekly basis. Steve, again, thank you so much.
Great,
Would it
thank
be
you.
okay if we record this or use the recording?
Oh, absolutely. Absolutely. Yeah.
Thank
Yeah.
you very much. Asil,
Yeah.
thanks
Thanks for
again.
attending, and thanks for the invitation. I really appreciate it.
You're welcome. All right.
Okay.
Bye, everybody.
Okay. Good night. Good night. Yeah.